All right, let's dive in. Today we're talking about something called Acrodermatitis Chronica Atrophicans. It's a mouthful, I know. But it's the final and often completely missed calling card of late-stage Lyme disease. It's the scar that never fades.
You know, that description right there, it was written over 100 years ago, and it is still the most hauntingly accurate way to describe this. Think about it. Tissue paper-like. It just perfectly captures the kind of profound, permanent damage we're talking about. This isn't just another rash. It's what's left after a long, drawn-out war fought deep inside the skin itself. So where does it all start? Well, the story of ACA almost always begins with a single, tiny, and usually long-forgotten tick bite. But how? How does that one little event kick off a condition that can just smolder under the surface for years, sometimes decades, before anyone even figures out what it is? That's the real mystery we're going to unravel today.
To really get a handle on this condition, you have to see it for what it truly is. This isn't just some weird skin lesion. No, it's an active front line in a war against a stubborn, persistent infection.
Okay, there's a key word here, pathognomonic. It's a fancy medical term, but what it means is that this sign is so unique, so distinctive, that if you see it, you've basically confirmed a diagnosis of late-stage Lyme disease. It's not like the early bullseye rash that, can fade away. ACA does not go away on its own. It's a flashing red light, a signal that the body's immune system tried and failed to get rid of that initial infection.
So ACA kind of unfolds like a slow two-act play. Act 1 is the inflammatory stage. You get this swollen, bluish-red patch. Honestly, it could easily be mistaken for a bad bruise or maybe just poor circulation. But then, over months or more often years, we move into Act 2, the atrophic stage. The inflammation fades, but it leaves behind this fragile, thin skin. That's where we get that tissue paper quality we talked about. It's the battlefield after the war is over.
Now, here's a really interesting question. Why is ACA something you see almost exclusively in Europe? Well, it all comes down to which specific species of Borrelia you're dealing with. In Europe, the dominant player is Borrelia afzelii, and this one is what we call dermatrophic. It just loves the skin. But in North America, the main bug is Borrelia burgdorferi, which is arthritogenic. It prefers to set up shop in your joints, which is why Lyme arthritis is the classic late-stage sign there. It's this incredible example of how your location on the map can totally change how a disease shows up in the body.
Okay, so you take that geographical quirk, you combine it with how slowly this thing develops, and what you get is a massive diagnostic puzzle. ACOA is a master of hiding in plain sight.
And this right here is the classic story. Picture this. An older woman comes in, she's had this weird patch of discolored, thinning skin on her leg for, say, 5 years. The tick bite that started it all, that happened ages ago, and it's totally forgotten. Her doctor, very reasonably, thinks it's a circulation problem, which is super common at that age. But none of the treatments for circulation work because that's not what it is. And believe me, this exact scenario plays out all the time. So how do you finally crack the case? It really comes down to a triad of evidence, 3 key pieces of the puzzle. It all starts with clinical suspicion. A doctor has to see those unique skin changes and think, could this be ACA? That's piece number 1. Piece 2 is confirmatory serology, a blood test looking for the long-term IgG antibodies your body's been making. And finally, if there's still any doubt, you can do a skin biopsy. And that will show a very specific kind of inflammation packed with plasma cells, sealing the deal.
Now, this brings us to an absolutely critical point about diagnosis. Because this infection has been going on for years, maybe even decades, the body has been pumping out a massive, sustained antibody response. So that IgG antibody test, its sensitivity is nearly 100%. It's almost perfect. This means a negative IgG test doesn't just make ACI unlikely, it pretty much rules it out completely. It's that reliable.
And this creates this really fascinating flip in how we test for Lyme disease. For an early bullseye rash, the skin is crawling with bacteria, so a direct test like PCR is your best bet, because the antibodies are just starting to form. But for late-stage ACA, it's the complete opposite. The actual number of bacteria in the skin can be super low, making PCR unreliable. But the antibody response throughout your whole body, it's overwhelming and absolutely definitive. So the right test to use is completely dependent on what stage of the disease you're in.
Which brings us to a huge paradox at the heart of all this. If the body is launching this massive immune response, and we have antibiotics that work, why on earth does this infection stick around for so long? I mean, here's the thing. In a lab, in a petri dish, the bacteria that cause ACA are pushovers. You hit them with standard antibiotics like doxycycline and they die. Easily. So this isn't a case of classic genetic antibiotic resistance, the kind of thing we worry about with superbugs like MRSA.
So there it is, the million-dollar question that's puzzled researchers. What is the disconnect between the lab and the real world? Why can an infection last for decades when the bacteria are so easy to kill on paper? Well, the answer isn't about resistance, it's about tolerance.
The leading theory here involves something called persister cells. Think of them like bacterial sleeper agents. A small group of the bacteria basically goes dormant. They slow their metabolism way down and just hide. Now, since most antibiotics work by attacking active processes, like building cell walls, these dormant bacteria just fly under the radar. They're not genetically immune to the drug, they're just phenotypically tolerant. They can ride out the antibiotic storm and then wake up later to get the infection going again.
And understanding this whole persistence thing is absolutely key to understanding the goals of treatment, and maybe more importantly, the limitations of that treatment.
So, to go after these persister cells, you need a long course of antibiotics. We're talking 21 to 28 days. The idea is to keep the drug in the system long enough to catch the bacteria as they cycle out of their dormant state. Oral doxycycline is usually the first choice. It gets into the tissues really well. But for more serious cases where the central nervous system might be involved, you have to bring out the big guns, intravenous ceftriaxone.
And this is the tough part. This is the hard truth for patients. The antibiotics, they can absolutely wipe out the bacteria and stop the disease from getting any worse. But the damage that's already been done, that thin skin, the scar tissue, the lost hair follicles, that's permanent. It's like we can win the war, but we can't erase the scars from the battlefield.
Now, while ACA is super rare in kids, it is important to know that there are clear treatment guidelines. The doses are basically just adjusted for weight based on the adult data. The one big thing to note here is the change in thinking about doxycycline. It used to be avoided in young kids, but now it's considered safe, and it's the first-line choice for all forms of Lyme, no matter how old the patient is.
You see, even after you cure the infection, that's not the end of the story for these patients. They are often left to deal with a lifetime of consequences from the damage that was left behind. The long-term picture involves managing this really fragile skin that can easily break down into chronic ulcers. And up to half of all patients will have permanent nerve damage, peripheral neuropathy, that causes chronic pain or numbness. But the most sinister risk, the one we really have to watch for, is that EACA is considered a pre-malignant state. Years of that chronic inflammation can actually trigger skin cancers, especially a type called cutaneous B-cell lymphoma. This means these patients need to be watched by a dermatologist for the rest of their life.
And all of this leads us to the most important takeaway of all. When you consider the irreversible damage, the chronic pain, the cancer risk, the only true cure for ACA is to make sure it never happens in the first place. This is where primary prevention is everything. Avoiding tick-heavy areas, using repellents, doing your tick checks, these aren't just suggestions. They are the only guaranteed way to avoid a lifetime of consequences.
So, to sum it all up, ACA is the signature of a chronic Borrelia afzelii infection, mostly seen in Europe. The diagnosis is a combination of what you see on the skin and a really strong antibody test. And the critical point is this. While we have antibiotics that can cure the infection, they can't turn back the clock on the physical damage, which is exactly why preventing that tick bite is the only real solution we have.
In the end, this condition is just a powerful reminder. It's not some obscure dermatological curiosity. It is the visible, permanent scar of a long-forgotten battle. A battle between a tiny, persistent microbe and our own immune system. And it's a battle whose consequences can and do last a lifetime.